Hey there, students. Welcome to a special edition of Everyone's Health. We are Equation by Pharmacist Moms, and today, we're diving into a topic that affects more than just our textbooks. It's about our heartbeat, our health, and our hustle. Get ready to embark on a journey of understanding as we unpack the mysteries of hypertension. Have you ever wondered about the silent force that can impact your well-being? Well, you're in for a treat. In this video, we're breaking down the basics of hypertension, exploring what it is, why it matters, and how it ties into our daily lives. So, whether you're pulling all-nighters in the library or sprinting between classes, join us as we decode the language of blood pressure and arm you with the knowledge to not only excel academically, but to thrive in the pulse of good health. Get ready for an enlightening journey into the realm of hypertension. This is not just about numbers, it's about your vitality as an individual. Are you ready to elevate your health IQ? Well then, let's dive right in. Welcome to the world of hypertension. By the end of this video, you will be able to understand: what is blood pressure? What is hypertension? Classification of hypertension based on blood pressure. What is the etiology of hypertension? What are the risk factors for high blood pressure? What can happen if high blood pressure is not treated? Hypertension and regulation of blood pressure, and basic pharmacology of antihypertensive agents. Let's begin. What is blood pressure? Blood pressure is the measurement of the pressure, or force of blood, pushing against blood vessel walls. Blood pressure is determined both by the amount of blood the heart pumps and the amount of resistance to blood flow in the arteries. What is hypertension? Hypertension is a condition in which the long-term force of the blood against the artery walls is high enough that it may eventually cause health problems, such as heart disease. Hypertension is the most common cardiovascular disease. Its prevalence varies with age, race, education, and many other variables. According to some studies, 60 to 80% of both men and women will develop hypertension by age 80. How is hypertension classified on the basis of blood pressure? Let's find out. A blood pressure reading is given in millimeters of mercury and has two numbers. The top number is the systolic blood pressure, which measures the pressure on the blood vessel walls when the heart beats or contracts. The bottom number is the diastolic blood pressure, which measures the pressure on the blood vessels between beats when the heart is relaxing. The 5 blood pressure ranges, as recognized by the American Heart Association, are: blood pressure numbers of less than 120 by 80 millimeters of mercury are considered within the normal range. If the results fall into this category, it is advised to stick with heart-healthy habits, like following a balanced diet and getting regular exercise. Elevated blood pressure is when readings consistently range from 120 to 129 systolic and less than 80 millimeters of mercury diastolic. People with elevated blood pressure are likely to develop high blood pressure unless steps are taken to control the condition. Hypertension stage 1 is when blood pressure consistently ranges from 130 to 139 systolic or 80 to 89 millimeters of mercury diastolic. At this stage of high blood pressure, doctors are likely to prescribe lifestyle changes and may consider adding blood pressure medication based on the risk of atherosclerotic cardiovascular disease, that is ASCVD, such as heart attack or stroke. Hypertension stage 2 is when blood pressure consistently ranges at 140 by 90 millimeters of mercury or higher. At this stage of high blood pressure, doctors are likely to prescribe a combination of blood pressure medications and lifestyle changes. If the blood pressure readings suddenly exceed 180 by 120 millimeters of mercury, an individual should test the blood pressure again after waiting for 5 minutes. If the readings are still unusually high, and he or she is experiencing signs of possible organ damage, such as chest pain, shortness of breath, back pain, numbness or weakness, change in vision, or difficulty speaking, he or she must contact the doctor immediately. He or she could be experiencing a hypertensive crisis. What is the etiology of hypertension? A specific cause of hypertension can be established in only 10 to 15% of patients. An individual could be diagnosed with one of two types of high blood pressure. First one is primary high blood pressure. It is also called essential hypertension. Causes of this most common type of high blood pressure include aging and unhealthy habits, like not getting enough exercise. Secondary high blood pressure. Causes of this type of high blood pressure include different medical problems and medications, including obstructive sleep apnea, kidney disease, adrenal gland tumors, thyroid problems. Certain defects an individual is born with, that is congenital, in blood vessels. Certain medications, such as birth control pills, cold remedies, decongestants, over-the-counter pain relievers, and some prescription drugs, and illegal drugs, such as cocaine and amphetamines. In most cases, elevated blood pressure is associated with an overall increase in resistance to flow of blood through arterioles, whereas cardiac output is usually normal. Precise investigation of autonomic nervous system function, baroreceptor reflexes, the renin-angiotensin-aldosterone system, and the kidney has failed to identify a single abnormality as the cause of increased peripheral vascular resistance in essential hypertension. It indicates that elevated blood pressure is usually caused by a combination of several or multifactorial abnormalities. Epidemiologic evidence, which contributes to the development of hypertension, include genetic factors, psychological stress, environmental factors, and dietary factors, including increased salt and decreased potassium or calcium intake. Increase in blood pressure with aging does not occur in populations with low daily sodium intake. Patients with labile hypertension appear more likely than normal controls to have blood pressure elevations after salt loading. The heritability of essential hypertension is estimated to be about 30%. Functional variations of the genes for angiotensinogen, angiotensin-converting enzyme, or ACE, the beta-2 adrenoceptor, and alpha-adenosine, which is a cytoskeletal protein, appear to contribute to some cases of essential hypertension. High blood pressure also complicates about 10% of all pregnancies. The types of high blood pressure during pregnancy include chronic hypertension. It means high blood pressure, which is present before pregnancy. Gestational hypertension. It indicates high blood pressure in the latter part of pregnancy. Preeclampsia. This is a dangerous condition that typically develops in the latter half of pregnancy and results in hypertension, protein in the urine, and generalized swelling in the pregnant person. It can affect other organs in the body and cause seizures or eclampsia. Chronic hypertension with superimposed preeclampsia. Pregnant people who have chronic hypertension are at increased risk for developing preeclampsia. What are the risk factors for high blood pressure? An individual is more likely to have high blood pressure if he or she has family members who have high blood pressure, cardiovascular disease, or diabetes. Is of African descent. Is older than 55. Is overweight. Don't get enough exercise. Eat foods high in sodium or salt. Smoke or use tobacco products. Is a heavy drinker, that is, more than 2 drinks a day in men and more than 1 drink a day in women. What can happen if high blood pressure is not treated? Sustained arterial hypertension damages blood vessels in kidney, heart, and brain, and leads to an increased incidence of renal failure, coronary disease, heart failure, stroke, and dementia. Effective pharmacologic lowering of blood pressure has been shown to prevent damage to blood vessels, and to significantly reduce morbidity and mortality rates. Numerous effective drugs are accessible. Knowledge of their antihypertensive mechanisms and sites of action allows accurate prediction of efficacy and toxicity. As a result, rational use of these agents, alone or in combination, can lower blood pressure, with minimal risk of serious toxicity in most patients. How is hypertension diagnosed? Let's discuss. The diagnosis of hypertension is based on repeated, reproducible measurements of elevated blood pressure. We have already discussed the blood pressure ranges, recognized by American Heart Association, in detail. Epidemiologic studies suggest that the risks of damage to kidney, heart, and brain are directly related to the extent of blood pressure elevation. Even mild hypertension, that is, blood pressure 140 by 90 millimeters of mercury, increases the risk of eventual end organ damage. Starting at 115 by 75 millimeters of mercury, cardiovascular disease risk doubles with each increment of 20 by 10 millimeters of mercury throughout the blood pressure range. It should be noted that the diagnosis of hypertension depends on measurement of blood pressure and not on symptoms reported by the patient. In fact, hypertension is usually asymptomatic until overt end organ damage is imminent or has already occurred. How is blood pressure normally regulated? Let's learn. According to the hydraulic equation, arterial blood pressure is directly proportionate to the product of the blood flow, that is, cardiac output, and the resistance to passage of blood through precapillary arterioles, that is, peripheral vascular resistance. Physiologically, in both normal and hypertensive individuals, blood pressure is maintained by moment-to-moment regulation of cardiac output and peripheral vascular resistance, exerted at three anatomic sites: arterioles, postcapillary venules, and heart, as shown in this figure. A fourth anatomic control site, the kidney, contributes to maintenance of blood pressure by regulating the volume of intravascular fluid. Baroreflexes, mediated by autonomic nerves, act in combination with humoral mechanisms, including the renin-angiotensin-aldosterone system, to coordinate function at these four control sites and to maintain normal blood pressure. Finally, local release of vasoactive substances from vascular endothelium may also be involved in the regulation of vascular resistance. Blood pressure in a hypertensive patient is controlled by the same mechanisms that are operative in normotensive subjects. Regulation of blood pressure in hypertensive patients differs from healthy patients in that the baroreceptors and the renal blood volume pressure control systems appear to be set at a higher level of blood pressure. All antihypertensive drugs act by interfering with these normal mechanisms, which we will review one by one. First one is postural baroreflex. Baroreflexes are responsible for rapid, moment-to-moment, adjustments in blood pressure, such as in transition from a reclining to an upright posture. Central sympathetic neurons, arising from the vasomotor area of the medulla, are tonically active. Carotid baroreceptors are stimulated by the stretch of the vessel walls, brought about by the internal pressure, that is, arterial blood pressure. Baroreceptor activation inhibits central sympathetic discharge. Conversely, reduction in stretch results in a reduction in baroreceptor activity. Thus, in the case of a transition to upright posture, baroreceptors sense the reduction in arterial pressure that results from pooling of blood in the veins below the level of the heart as reduced wall stretch, and sympathetic discharge is disinhibited. The reflex increase in sympathetic outflow acts through nerve endings to increase peripheral vascular resistance and cardiac output, thereby restoring normal blood pressure. The same baroreflex acts in response to any event that lowers arterial pressure, including a primary reduction in peripheral vascular resistance, for example, caused by a vasodilating agent, or a reduction in intravascular volume, for example, due to hemorrhage, or to loss of salt and water via the kidney. Here is the diagram for the demonstration of baroreceptor reflex arc. Second one is renal response to decreased blood pressure. By controlling blood volume, the kidney is primarily responsible for long-term blood pressure control. A reduction in renal perfusion pressure causes intrarenal redistribution of blood flow and increased reabsorption of salt and water. In addition, decreased pressure in renal arterioles, as well as sympathetic neural activity via beta-adrenoceptors, stimulates production of renin, which increases production of angiotensin II. Angiotensin II causes direct constriction of resistance vessels and stimulation of aldosterone synthesis in the adrenal cortex, which increases renal sodium absorption and intravascular blood volume. Vasopressin released from the posterior pituitary gland also plays a role in maintenance of blood pressure through its ability to regulate water reabsorption by the kidney. All antihypertensive agents act at one or more of the 4 anatomic control sites, which we have already discussed in this video, and produce their effects by interfering with normal mechanisms of blood pressure regulation. A useful classification of these agents categorizes them according to the principal regulatory site or mechanism on which they act. Because of their common mechanisms of action, drugs within each category tend to produce a similar spectrum of toxicities. The categories include diuretics, sympathoplegic agents, direct vasodilators, and agents that block production or action of angiotensin. We'll briefly discuss them one by one. First one are diuretics. They lower blood pressure by depleting the body of sodium and reducing blood volume, and perhaps by other mechanisms. Second one are sympathoplegic agents. These agents lower blood pressure by reducing peripheral vascular resistance, inhibiting cardiac function, and increasing venous pooling in capacitance vessels. The latter two effects reduce cardiac output. These agents are further subdivided according to their putative sites of action in the sympathetic reflex, which we will discuss in our upcoming videos. Next are direct vasodilators. They reduce pressure by relaxing vascular smooth muscle, thus dilating resistance vessels, and to varying degrees, increasing capacitance as well. Last one are agents that block production or action of angiotensin. These agents block production or action of angiotensin and thereby reduce peripheral vascular resistance and potentially blood volume. The fact that these drug groups act by different mechanisms permits the combination of drugs from 2 or more groups, increased efficacy, and, in some cases, decreased toxicity. And there you have it, fellow students. We've unraveled the fundamentals of hypertension, and we hope this journey has left you feeling empowered and informed. Remember, your health is your greatest asset, and understanding the rhythm of your own heartbeat is key to achieving academic excellence. If you found this video valuable, don't forget to give it a thumbs up and share it with your fellow students. Subscribe to our channel for more health insights tailored just for you. Thank you for joining us on this exploration into the world of hypertension. As you navigate the waves of student life, keep in mind that your well-being is a priority. Until next time, we are Equation by Pharmacist Moms, signing off. Stay healthy, stay focused, and keep rocking those grades.